right, so I mentioned to the group this morning that, I'm far enough away from you, right? Yeah.
Good.
That there was a question about reversal of action, and again, I'm reading on my phone as I'm having a glass of wine, and so, it was the concept of, the way it was written was funny, but the.
Yeah, I understand.
Okay, you understand, okay. That, we talked about origin moving toward insertion, insertion moving toward origin. And we mentioned it today in today's lab. So those of you who have, Professor Nafrio, I don't know if he mentioned it to you, but I'll mention it again. So we'll just take the biceps and we'll make it real simple. We won't talk about the anatomical structures. We'll say shoulder and we'll say forearm, okay? So if the muscles originating here in the shoulder and inserting into the forearm, as I bring, this is the insertion, this is the origin. As I bring the elbow up, this is normally the way a muscle works. If I were to do a pull-up, my forearm is stable, and what is moving toward the forearm? The shoulder. That is reversal of action. Okay? Usually, the origin is more stable than the insertion, but there are times when that is the opposite. It is not the same thing as open and closed chain exercise. Because, for example, I could have my trapezius performs shoulder elevation or scapular elevation or shoulder shrugging. If the scapulae were fixed, then my head would rotate and side bend. So you can't say that's a closed chain exercise, okay? And I gave another example which may help some people and it may not. The gluteus maximus originates, let's just say for the sake of just saying, it's originating on the pelvis and it's inserting into the femur. So when it contracts when the insertion is pulled to the origin, how does my leg look? Like this, right? So it pulls, the insertion pulls toward the origin. So that is hip extension, right? But if I'm flexed over like this and the femur is flexed, the origin now will move closer to the insertion in picking me up. So the gluteus maximus, through its reversal of action, can extend my trunk. Okay? So we'll get into this. I'm not going to ask this on the test, all right? Because I really think it's important for you to know the origins and insertions of muscles and the actions before we do this. I just wanted to throw that out there. So I think this is the perfect example, right? You can see the shoulders moving toward the forearm, and you can see that the forearm is moving to the shoulder. Okay. There will be a 25 question, well, probably 5 of them will be abbreviations on Tuesday. Okay, this Tuesday. Next Thursday will just be lab and lecture. And the following week, so I don't have the dates, but Oscar, you can figure out the dates. The following week, that Tuesday, we will just do a practical exam. Everyone was going to get, so we won't have a lecture that day because it'll just be a practical exam, and we need all those hours to do it. Followed by, and I'll write down the schedule for you so you know who's going to go at what time. Followed by that following Thursday now, being a 50-question multiple choice exam. Okay? So this Tuesday coming up will be a written 25-question exam, open-ended. That Thursday, what dates are we talking?
September 29th.
September 29th is Thursday?
No, that's a Tuesday quiz.
Tuesday?
Tuesday quiz this coming up.
So Tuesday's, the quiz is September 29th. September 31st is just lecture. October 6th is practical exam
And
for
the
transfers and range of motion,
And the history of physical therapy paper.
and history of physical therapy paper. And the following Thursday is
The
50-question exam.
The
Okay.
25-question exam is gonna be on,
Everything we've done so far.
and then what's the 50-question?
50-question is everything we've done to that point.
Oh, okay.
But that 50-question, when I do the exams in that format, I'm gearing them more to the type of exam you would have on the state board, those kind of questions. These questions I'm giving you on Tuesday are open-ended, so I know you understand what we're talking about,
Professor, what's behind you?
okay? So I'm gonna say to you, explain or define, rather than just pick out A, B, C, D, okay?
Watch behind you. Your stuff. Your
Oh,
right
thank
stuff
you.
on.
Thank you.
History. Professor, how is the practical exam going to work for the Monday, Wednesday class?
Everyone's gonna be tested on the same day. That's why I said we're gonna do it on one day. The Monday, Wednesday class will have their practical later, because you guys are scheduled to come at 11:30. So if you don't have any, and you're gonna let me know, so you'll let me know. If you guys don't have anything to do earlier, and we get done with the Tuesday, Thursday class first, we can move you guys up and get you out of here earlier. But if you know, some of you have classes or something else to do, please let Ashka know, and I'll arrange for you guys to be tested later. So the Tuesday, Thursday, the people that are here all day will be tested first. The Tuesday, Thursday group will go first. The Monday, Wednesday group will come after that. Yes.
So will our Monday, Wednesday lab schedule remain the same for that week?
Yes, you'll still be in lab. Yes,
So if the Monday and Wednesday is going later, how late is it gonna run?
I really can't hear you.
If Monday, Wednesday is going to come later, how long is the exam going to run for?
It's not gonna run past 1.
Okay.
No, it won't run past 1. In fact, it will probably be done by 12, I would think, because we have 5 people. So I'll plan it all out. You know, that's not for a week and a half, so by Tuesday, I'll have all of you go, well, you can't be paired. Generally, I pair you randomly, but I'm not going to. I'm gonna pair you with your partner that you've been working with. So you know who that partner is. I'll just assign times to you, okay? Is there anybody who can't come early? Let's say we finish the first group by 10. Can the rest of you on a Monday, Wednesday schedule be here by 10? Yeah, not a problem? All right, so then we'll probably get done pretty early.
Professor, we don't have lecture that day?
It depends. Generally, we don't, because what we do is we do it over a long period of time. We may not have to, because we have additional people. So can we play this by ear for this first one, because it's the first time we're really doing this. Usually it's like 2 people testing you, and it takes a lot longer time. Now we have 5 people, so it's gonna go quicker. Okay? All right. So what's the difference between a closed and an open chain activity? Can you demo an open and chain closed activity? Cindy?
What's that?
Yeah, can you demo that?
I didn't hear you. Can you say it again?
Can you demonstrate an open and chain? How about, oh, no, forget Cindy, I pick on you a lot. Chris, can you demonstrate an open and closed chain triceps activity?
Tricep. Does that include, does it have to be isolating the tricep or can it be?
No,
No. Is it appropriate for me to get up on this thing so everybody can see?
push on it and see if it falls.
I think okay. So a closed chain demo of something using my triceps, I would say is here.
Okay,
Open chain using my triceps. How about if I were to, I don't know if I'm strong enough, but if I were to do this?
yeah,
Okay.
good. Okay, so the arm is free to move in space as opposed to being fixed, open and closed chain. And we gave the demonstration in class about a quadriceps. quadriceps, do knee extension, and if I sat on this and I went on one of those ridiculous machines that people use in the gym and do this, that's knee extension, right? But then if I were to do a sit to stand, it's the same knee extension, but it's in closed chain because the distal extremity is fixed, not free to move in space. Okay. So, we talked about joints, and by the way, I told you guys next week, on Tuesday, we will start passive range of motion. So I expect you to read what motions occur where. Like glenohumeral joint has 3 degrees of freedom, 3 degrees of freedom constitute flexion, extension, abduction, internal, external rotation. And then I would know how to move that joint, okay? So scapulothoracic joint is not a true joint, which we will learn. But there are other joints that we will move, like radiocarpal joint, metacarpophalangeal joint, femoral, acetabular-femoral joint, all these joints we will move. Occipital-atlantic joint. Okay. Now, muscles, we talked about the location, we said the insertion moves to the origin, blah, 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 blah. I think we were here, right? Somewhere around here? Did we pass here?
Yeah, we're here.
We're here?
Yep. Muscle fiber arrangement.
Muscle fibers. Just here, or did we pass here?
We did this one.
We did this one. We did, oh, we didn't do this one?
No, we just talked
All
about
right,
the
so there are fibers that are parallel to the long axis of the muscle. Those arrangements are, they're in line with the muscle, parallel to it, in line with the muscle. They're longer, and there's a greater range of motion associated with those parallel muscles. And those are, some of the muscles are known as the strap muscles. The SCM is an example of one of those muscles. Then there's oblique, or those oblique muscles are attached at an angle, and they're usually shorter and they're much more numerous, and they are associated with greater strength potential like the deltoid or the abdominal muscles. Okay? So oblique, we think of the oblique pennate feather. You think of a unipennate, one part of a feather, so one side of a feather, and a muscle that looks like this is the tibialis posterior. Tibialis posterior is on the posterior port of the leg. Tibialis posterior is an important muscle to maintain the arch of the foot. Okay, so we'll talk about that a little more. We'll talk about what it does as a plantar flexor as well as an inverter, and it's very important to stabilize the foot's arch. So sometimes if somebody's got a tib posterior dysfunction or a tear, you see them wind up with a flat foot, and usually the calcaneus is either everted and then the navicular starts to fall.
It's a plantar flexure and what else?
A dysfunction, a rupture or dysfunction.
So what does it do? The tibialis posterior?
It also plantar flexes and inverts the foot. Okay, it's on the posterior calf. So bipennate is when, it looks like a feather, so something like that is the interosseous of the fingers as well as the gastrocnemius. Gastrocnemius is a 2-joint muscle in the leg. Everybody knows what gastrocnemius looks like because some of you people that go to the gym, you say, I want my calves to be big. So you do these, you know, these, I don't know, all these crazy things. But it's a 2-joint muscle. It's actually originating on the femoral condyles, medially and laterally, and inserting into the calcaneus via the Achilles tendon. So this muscle inserts into a bone on the foot via that Achilles tendon, which we were able to palpate. Okay, so that's a pretty strong muscle. It helps you overcome your body weight, but does not help you to stabilize the leg during unilateral weight bearing. That's more the soleus muscle, which we'll get into at a later time. And then there's multipennate muscles that have many tendons or many actions and converging into one tendon. So there's tendons that converge into one. And when we think about that deltoid muscle, we think about that we have an anterior, a middle, and a posterior deltoid. Does anybody remember me ever saying what it does?
Yes.
Yeah. So the anterior deltoid, and I'll say it again because we'll have it during muscles, is a flexor and an internal rotator. The middle deltoid, along with the others who assist, is an abductor. And a posterior deltoid is an extensor and an external rotator. So we have a lot of actions at this. It's a large muscle that is the cap of the shoulder and inserts where? Into that deltoid tuberosity. Okay. talked about, I said, long and thin, these fibers are on these strap muscles. They usually refer, and if you talk to any speech pathologists, they'll always talk about the strap muscles. Strap muscles are these muscles here. They're muscles that attach to the hyoid, go from the hyoid, omohyoid specifically, goes from the hyoid to the scapula, very cool muscle. Strap muscles are the ones that we know of right now, are like infrahyoids and suprahyoids. So generally, and SEM. So those are what strap muscles are. There's also sartorius. Sartorius is a very long muscle. Sartorius is also known as the tailor's muscle. Why is it known as the tailor's muscle? Because tailors, we used to go to tailors, right, when they used to make your clothes. And what a tailor does is sit like this, and that's exactly what the muscle does. Okay, it externally rotates, it abducts, it flexes the knee. The sartorius is actually originating on the ASIS and inserting into the medial portion of the tibia in something known as a pes anseritis. It inserts into the proximal medial side of the tibia along with two other muscles. But for right now, just remember that it's known as the tailor's muscle, okay? Because if you remember that, then you remember sort of what it does, okay? We'll get into this in a couple weeks. All right, fusiform spindle shape, tapered ends, and examples, the biceps. We already talked about what the biceps did. Rhomboids have 4 sides, and how convenient, we have a rhomboid major as well as a rhomboid minor muscle. So they're rhomboidal in shape. And then triangular, these are larger muscles. They radiate from a narrow attachment. They're fan-shaped, and one of the examples is a pec major. So here's the oblique as opposed to parallel. So when we talk about muscles, we say that they contract. When a muscle prepares actually to contract, we have myosin, and this myosin reaches out to actin, and these actin filaments are pulled together, and as they're pulled together toward one another, they cause the muscle to shorten or to lengthen, okay? Well, they actually, when they pull toward one another, they're actually shortened or contracting. So that's what's happening when we have a contraction of a muscle. And we have sarcomeres, which are the contractile units of the actin and myosin itself. So, and this all requires energy as well as calcium to cause this action to occur, okay? That's all we need to know about it. We just need to know that a muscle is going to contract, shorten, or elongate. And it's done through these, the actin binding to the myosin, pulling it together. Okay? Stretching is actually done to increase the resting length of the muscle. So stretching is not the same thing as passive range of motion. Passive range of motion, we take the patient's limb to the available end range. Once we go past the available end range, we are stretching. Okay? Stretching is not something we want to do when we do passive range of motion. There are times we want to stretch a muscle. The other thing we don't want to do is ballistic stretching, because ballistic movements do not actually stretch the muscle, they cause the muscle to contract. Because when you ballistically, and you know what I mean? Somebody says reach your toes and bounce, bounce, bounce. Every time you do this, you activate the muscle spindle, which goes to the agonist, and in this case would be the erector spinae or the paraspinal muscles, telling the muscles to contract. So when this happens, what happens to the paraspinals? They get shorter. What happens to the tilt of the pelvis? It becomes more anterior. What happens to the ability to reach the floor? It becomes less. Okay? So we're going to prevent ballistic stretching. Okay? We're cool with that? And we will talk about individually the Golgi tendon organ as well as the muscle spindle next semester. We already said that biomechanics is a branch that involves, it takes the mechanics actually and applies it to the human body. So this is science. It deals with forces, deformation of the bodies. If you hit an object that's static or it causes something known as inertia. And when we talk about levers, we've talked about a lever system, and I'll tell you how very easily to remember this. But a lever is just a rigid bar that rotates about an axis. Okay? When you need to overcome some kind of a force or resistance that's placed on it. Think of a seesaw. You have a lever and you have an axis and you have resistance on one side as opposed to the other. If the resistance is equal, then the person doesn't go up or down. If the resistance is greater on one side, then the person goes up on that side. Okay, so there's this lever system is this an axis that's there is causing this motion to occur. All right. So the law of inertia, an object at rest stays at rest, and an object in motion tends to stay in motion. Isn't that the case? If you're on a subway car and your hand is up on the strap and the subway car goes, and it's going in motion, and then all of a sudden the conductor hits the brakes, what happens? You keep going, right? So an object in motion tends to stay in motion. If you're sitting at a red light and somebody hits you from behind and you're not moving, what initially happens? An object at rest tends to stay at rest. You go into extension. Sometimes you go into extension followed by flexion, followed by extension, and you kind of have a coup-contra-coup motion of the brain that's swishing around back and forth. But an object at rest stays at rest unless there's a force that's acted upon it. And an object in motion stays in motion unless there's something acting upon it to stop it. So if I roll a ball and there's no friction on the ground, like grass or anything else, it's just going to keep going, right? So there has to be some kind of resistance to slow it down. That's the law of inertia. Law of an acceleration is the change in velocity of an object. So force equals mass times acceleration. If you kick a soccer ball with the same amount of force as you kick a bowling ball, which is going to go further? The soccer ball, because it's a lot lighter because it involves the mass, right? So acceleration actually equals force over mass, where mass is inversely proportional to the acceleration. And that's just that example I gave. By kicking a soccer ball as opposed to kicking a bowling ball. Okay. And then finally, the law of action and reaction. For every action, there's an equal and opposite reaction. If you jump on a trampoline and you just start jumping lightly, it just gives you force back slightly, and you don't go up that high. The further or the greater force that you exert as you jump, the more it's going to push you up. Okay? Now, when we get to levers, I'm going to give you a really easy way to remember it. So we have an axis, which is the fulcrum. We have a force arm, and we have a resistance arm. Okay? So the force is the force that needs to be applied. The resistance, so the force usually is the force that needs to be applied by the therapist, if we're going to talk about therapy. The resistance is what the person is providing us, usually through a body part, right? Or we could put a weight on his arm and increase the resistance with which he has to raise his arm. And the axis in the human body would be the joint. Okay? So there's three types. There's a first class, force is on one side, weight or the resistance is on the other side, and the axis is in the middle. So think about that seesaw, right? Force on one side, resistance on the other side, axis in the middle. Second class lever, the axis and force are on the opposite side with resistance in the middle. So think about a wheelbarrow. Where's the axis? The wheel. Where's the resistance? Whatever's in it. Yes? And where's the force? It's the arms that are extending that you're pushing. Yes? Okay. And the third class lever is the axis and the resistance on either end and the resistance in the middle. Now, levers will all present to us a mechanical advantage. I want you to remember what's in the middle of each one of these, and you'll never forget how to determine what lever system you're dealing with. So I said for the first class lever, the axis is in the middle. For the second class lever, the resistance is in the middle. And for the third class lever, the force is in the middle. Write those things, write just what I said, and use A for axis, R for resistance, and F for force. Just write those three letters. What do they spell? ARF. Those of you who English is not your first language, ARF is kind of like what we say when a dog barks. What does he say? ARF. Yes? No? Maybe? Maybe I'm old? Okay. ARF. That's a really simple way to remember what class lever you're dealing with. Okay. A-R-F. Okay. So let's take the biceps. What's the biceps do? Flexes the elbow, right? So, what joint am I moving? You can tell me in lay term. Elbow. Okay, elbow. So what is the axis? The axis is the joint. So what is the axis? The elbow. The force is the insertion of the muscle. Okay. I told you guys that the insertion of the biceps is the radial tuberosity. The radial tuberosity is right here. Right here. Here's the axis. Here's the radial tuberosity. What's the resistance when I do this? What's the resistance? When I do this, where's my resistance?
Your head,
Everybody.
your weight of the forearm.
Rich, where's my resistance?
Gravity.
Huh? The forearm. The forearm is my resistance, right? Okay. So, I want you all to tell me what class lever this is. Because the rest of them didn't take your class. And you talked to me about your crossed syndrome. All that is your right, your anterior and your posterior are different, right? Will be first? Who says first? Who says second? Who says third? Who's not thinking? Because a lot of you didn't raise your hand. Casey?
I got second.
What do you have?
Third.
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 The answer is third. Okay? Because your axis is here. Right? Your force is here. And your resistance is here. So what's in the middle? Your force. Yes.
So for the third class, the force is in the middle? For the third class, the force is in the middle?
Yes. A-R-F. Oh, I'm sorry, cross that out. Thank you for seeing that. Can we change that now? Nobody's ever picked that up. Let's change that right now. See? That is wonderful. I'm so glad that you saw that. Oh. Okay, but when I said it right, right?
Yeah.
Okay.
What?
I said it right. A-R-F. Axis is in the middle for first class. Force is in the middle for second class. Resistance is in the middle for third class. I'm sorry. Resistance is in the middle, A-R-F. Axis, first class. Resistance, second class, force, third class.
Example of a third class vehicle would also be, say, a baseball bat, right?
Shh, because we're gonna ask that. You can't, you know this, so don't, I know you know this, but they don't.
I'm just making
So you
sure.
don't have to tell me what you know. I don't tell you what I know. Yes.
So I think why I thought it was first is because I was thinking that the force is the muscle, but it's the insertion is what you're saying. That's the force.
The force is always the muscle insertion.
Muscle insertion, not the muscle actually doing the work.
Muscle action has nothing to do with, well, nothing that has anything to do with it, but we're talking about the axis, the force, and the resistance. So the action is actually lifting the forearm, where the forearm would be the resistance. Okay? I can give you a hard one, but I don't want to give you a hard one right now. I'll give you another easy one. I think it's easy. Quadriceps, knee extension. Okay, so everybody imagine just extending your knee from a sitting position. Okay, so all I'm doing is this, extending. Right?
Okay.
Quadriceps insert into the tibial tuberosity.
So it's
You
first.
guys all have palpated your own tibial tuberosities. You know where they are.
Is it first?
What lever is this? First, second, or third?
First. No, I think it's a first.
Corey? That's Corey. First, second, or third?
I'm gonna say first.
Andrew? Andrew says third, Corey says first. Who says first? First?
Yeah.
Who says second? And who says third? The thirds have it. Most joints in the body, most lever systems in the body are third class. Third class for range of motion. Okay? So, but why is that? Why is that? Because we have to explain it. So, can you explain it? Andrew? Can you explain it to Corey? Where's the axis? The axis is the knee joint. So, where is the force? The tibial tuberosity, because that's where the muscle inserts. The force is located at the tibial tuberosity. Is the tibial tuberosity distal or proximal to the patella? Distal. So the knee joint is proximal to the tibial tuberosity. So you following me? And then the resistance is the weight of the leg. Okay? All right, now I'm gonna, yes,
So the force is where the insertion is, right?
yes,
Okay.
yes. Okay, yes.
if most joints are third class, would be a second class.
How do I turn a third class into a second class? Easy. Take a muscle like the brachioradialis, or, as Casey's gonna tell you, you could put a baseball bat in your hand, right? Casey. Okay. But I'll use my way, only because we're talking muscles now. There's a muscle known as the brachioradialis muscle. Brachioradialis muscle also flexes the elbow, and it flexes the elbow this way. So it's originating on the supracondylar ridge, so that's located above the lateral epicondyle. Supracondylar ridge, inserting into the styloid process of the radius. Okay? If I just do this, here's the axis, here's the force on the radius, right? And here's the resistance, right? Force, what class is it? What class is it? Axis, resistance, force. It's a second class. Wait, my resistance? No, I'm sorry. Force is here, resistance is here, axis is here, right? A, R, F. Yes, I'm sorry. That's a second class, right? Now, I place a weight in my hand, and I ask a patient to lift up. Now where's the resistance? I changed the resistance, so what did I make it? I went from a second class to a third class. Okay?
Professor,
Yes.
so it's where the majority of the resistance is, because the hand is a little bit of resistance in that first example, but the forearm is more of the resistance.
Well, yeah, the forearm is really the resistance. As I start to put something heavy in my hand, I changed where the resistance is. The resistance is coming now from here, not so much from here. The hand isn't providing that much resistance unless I put something heavy in it. Yeah. Okay? So what is mechanical advantage? It's equal to, mechanical advantage equals FA over, all right. So if the force arm, so if mechanical advantage equals force arm over resistance arm, if the force arm is greater than the resistance arm, I'm going to throw this out to you. If the force arm is greater than the resistance arm, do I have a better or lesser mechanical advantage?
Better.
I, as a therapist, if my force arm is greater than what I'm trying to overcome in you with a limb, a resistance arm, my force arm is greater, am I going to have a better or lesser mechanical advantage? Better. If your resistance arm is greater than my force arm, I'm going to have to work a lot harder to overcome that resistance, right? Yes? Yes. Trust me, yes. That's why I say to you, shorten the lever arm, right? That's why I keep saying that, and that's why I say that. All right, so in first class levers, since the distance is between the force and the axis and resistance are equal, this ratio is a 1-to-1 ratio, and this is good for balance. Your book is an example that I don't like. It's your head, where the axis is in the middle, the resistance is the head, and the force is are the muscles pulling up the head. I just don't like that example, but some of you may read it and think it's a good example. So this is we always want our head balanced on our neck, so that's why this lever system is good for balance. Second one is good for power. And it's usually used, and you see it when you have large weights that you have to move around. So if we have a second class lever, or we have use of a second class lever, we could lift heavier weights easier by having a longer force arm, and that's seen when you're dealing with some wheelbarrow, putting something in a wheelbarrow. And a third class lever is the most common lever we have in the body, and that's used for range of motion. Even just taking our hand and bringing it to our mouth, as we would with biceps and brachialis, to feed ourselves. So that's used for range of motion.
So when you have people who just say they're doing bicep curls, right? Once they get to a point of fatigue where the force arm that you would see, say, in the biceps is because it can't produce enough force compared to resistance, that's where you have like the sticking point, right?
That's where you're gonna get hurt.
Where the mechanical advantage is less than one.
Correct. Correct. So what would I do in that case? I would decrease the weight and increase the reps. That's all. Okay. All right, so here's a picture of what I told you. The axis is the neck, the force arm is are the extensors of the cervical spine, and the head is the resistance. So that's an example, or a seesaw, an example of first class. Second class for power. So here's the resistance, and it's always good to have a picture. Here's the resistance, here's a nice long force arm, right? Isn't this force arm greater than this resistance arm? So here, this little thing right here is the resistance arm. This whole thing is the force arm. That's a much greater mechanical advantage, okay? And then your book also gives you this example, the force being the gastrocnemius to take you on your toes, the axis being the metatarsals as you stand on your toes, and the resistance being the tibia as it falls forward. Okay, so that's another example. And then the third class lever, we talked about this being the biceps, and your book gives you this example of the hinge of a door, and the force being the spring, and the resistance being the door itself. Okay. So what's the important thing to remember about this? The ARF, right? And to remember that most of what we have in our body as far as levers is third class for range of motion. Do we have power levers? Yes. Can we make a power lever? Yes. And we already talked about this brachioradialis, where we now change the resistance arm, because here's the force, it's a long force arm, and here's the resistance arm. So we made it from a second class lever to a third class lever. All right. This is just what I said before. It's just a nice picture. If the force arm is less than the resistance arm, you have to lengthen the force arm or add more force to overcome the resistance. Yes? Why would we want to do this when we can shorten the lever and make a better mechanical advantage for ourselves? You getting it? Okay. All right. So here, applying force to a patient's lower leg. You see the resistance arm and you see the force arm. So in A, greater force is required by the PTA in A, right? Because my force arm is smaller. If I put my hand down above the ankle and tell that patient to hold that up, less force is required by that PTA in order to overcome that resistance. So, yes? And this is really important when we talk about manual muscle testing. Can you hop up here?
Sitting? No, sitting?
Sideline. Do you mind?
No.
Okay, just sideline. Face that. Face the wall. Give me this leg. Put this leg up. Oh, don't fall off. Okay, hold that leg up. 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 Okay, ready? Hold that leg up.
Oh, no.
Okay, so go ahead. That's fine. So what did I do?
Let me try some rubber horse.
It was
What
tough.
did I do?
Yeah.
I did this, right? Mechanical advantage was better for myself, and that's how I made it in order for me. And we'll learn that these are different ways that you could test muscles. And this is also referred to when you're lifting and you're moving, right? Bring that object close to you, decrease that lever arm, etc. Bring your center of gravity closer to that person's center of gravity. Thank you, I'm sorry.
No, sorry.
You're
I'll
not
work
that
on it.
strong.
You wouldn't be able to close mine.
I wouldn't be able to push yours? In a second. In a second. Because you probably don't use your glute med the right way. I've watched you.
I got a good one.
I'm not so sure. You
I've
might
been
have
to
an
glute
anterior,
meds.
but not a posterior. You don't have a good posterior. Yes. Well, we'll do it.
Yeah.
The resistance itself, if it's, very tight space, that's the resistance arm. Resistance is the same as resistance arm.
Correct.
And the distance from the resistance to the force is the force.
Correct.
To the leg.
Correct. Okay? All right. So, let's see, where are we? Muscles. Okay, agonist. Agonist is the prime mover. So, in the case of elbow flexion, remember I told you, do you guys remember? I said, what is a biceps? It's a flexor of the elbow, right? But is it the prime mover of elbow flexion? Those of you who were in my lab, I probably told. The other guys in the other lab, I probably didn't tell. But as I go to bend my elbow, and when therapists test the strength of the elbow, they move the arm in different directions because a biceps is a strong supinator. It's not the strongest flexor. Okay, the agonist or the prime mover for elbow flexion is a brachialis. okay? The brachialis is a stronger muscle. So when I test, do muscle test, I test this way, I test this way, and I test this way. So I tell somebody, hold your arm, don't let me move you down. So can I have you again? You chose to sit up here.
I didn't warm up though. I didn't.
All right, I'm sorry,
Yeah.
I don't want to be real close to you, but, so if I hold him here and they say, hold here, don't let me push you down. And then I say, hold here, don't let me push you down. And then I say, hold here, don't let me push you down. I'm testing the brachioradialis, I'm testing the biceps, and I'm testing the brachialis. Okay, thank you. Three different ways to test elbow flexion, but I'm looking for specific muscles. So the agonist is the prime mover associated with elbow flexion. Okay, that would be the brachialis. It wouldn't be the biceps. That would be a synergist. Synergist works with other muscles to do the action. Okay, so that's a definition of a synergist. An antagonist is the muscle that performs the opposite motion of the agonist. So they're prime mover. So what is the antagonist of the brachialis? Triceps. Yeah. So the antagonist is the triceps because the triceps is an elbow extensor. The anconeus or the anconius is an assister, which would be a synergist of triceps. You don't have to know that now, but I just want you to know what these definitions mean. Co-contraction is when two groups of muscles are working together at the same time. So if you think about that child learning to walk or anything, anytime you're starting to do a novel task, you usually get co-contractions of flexors and extensors in order to perform an activity. Okay? A stabilizer is a group that supports when other muscles are doing their thing. So earlier Chris did a push-up, and he was using his triceps to push up, and the serratus anterior was stabilizing the scapula as he was doing it, and the abdominals were stabilizing the trunk. So they're stabilizers so that the other muscles can perform their activity efficiently and effectively. Okay? As opposed to a neutralizer, and a neutralizer works when you have two muscles working together, and they do two actions, but only one is wanted. So if we think about something like the extensor carpi radialis and the flexor carpi radialis, there's a flexor carpi radialis longus and brevis and the extensor carpi radialis. Flexor carpi radialis extends. Oh, there's also flexor carpi radialis and an extensor carpi ulnaris. Okay, so they both, or flexor carpi radialis and an extensor carpi radialis, sorry. So they both, one flexes and one extensus. If we just want radial deviation, they cancel each other out, and we just get radial deviation. Because one does flexion, one does extension, they neutralize one another just to get radial deviation. That's the example I wanted to give you. Okay? So these are the definitions associated with how muscles can work. All right. Functional excursion we talked about. We said it's, yes.
So one muscle can actually change roles, right? It's not always a synergist, it's not always an
It
agonist.
depends what the action is.
Well, like in the example you just gave, it was a neutralizer, whereas in other examples, it could be the agonist.
There could be a synergist associated with that agonist, yes.
Oh,
Yes.
No, I had a similar question. The agonist, you said is the prime mover.
The agonist is a prime
So
mover.
is that prime mover of a joint or of a motion?
Is that prime mover what?
Of a joint or of a motion? So like,
At the joint?
yeah, so
Of a joint or a motion?
like the prime mover, like you said, was
Prime mover relates to the muscle itself, not the muscle itself, not the joint.
Got it.
Okay? The muscle performing the action, whatever the action is.
Okay.
Okay. So we said what functional excursion was. We said functional, we gave you the example the other day of a muscle is 6 inches and it could shorten half, and it can elongate 1.5 times its times, and the functional excursion, remember that example?
Yeah.
And we said it went to 9 inches, it started at 3, so the functional excursion is 6. Okay, so that's functional excursion. Active insufficiency. Active and passive insufficiency only refer to two joint muscles. Okay? I want you to remember this. Active insufficiency deals with the agonists, and passive insufficiency deals with the antagonists. Okay? Active insufficiency and passive insufficiency refer to two joint muscles, where an active insufficiency deals with agonists and passive insufficiency deals with antagonists. Yes?
So, in this case, for example, like elbow flexion, the active insufficiency would be the bicep muscles, and then the passive would be the triceps.
Okay. Let's
If
talk.
that's,
Let's, not really, wait. Let's talk about, because a two joint muscle crosses two joints and has an action at each joint it crosses, right? So think about a hamstring. Let's take the hamstring. Okay. Hamstrings originating on the ischial tuberosity, inserting into either the lateral side or the medial side of the knee. So the fibula and the lateral tibial condyle, or on the medial side, etc. Hamstring flexes the knee, but extends the hip. So it runs out of space. It can't do both efficiently because it runs out of room. Okay? I could flex the hip and flex the knee, but I can't extend the hip and flex the knee. I start to get cramping. This is active insufficiency of the hamstring. The hamstring extends the hip, it's the agonist, right? Flexes the knee. I can't do both. Can any of you? Can any of you get up, extend your hip, and flex your knee? Flex your knee fully. Well, what starts to happen? Your legs start. Oh, Ate, what happened? Did you get a cramp? All right, that is active insufficiency of the hamstring muscles. They don't have enough length to do both things at the same time. Something's got to give, right? Take that same muscle. Can you line up?
Prone?
No, come on. And you've got pretty decent hamstrings. Oh my God, why are you so good?
Attaboy.
No.
I think I like that those hamstrings. Tighten them up. Here we go.
Okay, passive insufficiency refers to the antagonist, right?
Yes.
I'm an narcissist right now.
Oh my God.
Come on. Steve.
This
real?
is it. I would be on top of him holding his leg down and trying to get it up. He can no longer go into hip flexion because he has passive insufficiency of his hamstrings. The action we're looking for is hip flexion. The hamstrings are two joint muscles that are passively insufficient that will not allow me to go any further. But, watch this. I bend the knee and the hip goes further. Why? Because I put the muscle on slack. Okay? So that is the difference between passive and active insufficiency of one muscle. Yes?
So, like, for example, if the is dead, the reason why I cannot go any further through hip flexion is due to passive insufficiency of the hamstring muscles.
Well, there was no longer passive insufficiency because I flexed the hip.
Oh,
I flexed the knee.
Yeah.
There was no longer passive insufficiency. I wasn't asking that muscle to elongate over those two joints. It can't. So I put it on
Because
slack.
it's two joint muscles.
Yes, only two joint muscles. Only two joint muscles. Okay? So active insufficiency to the point where a two joint muscle can't shorten any longer. Passive insufficiency at the point where a two joint muscle can't lengthen any longer? Who's got tight calves? Anybody?
My right one right now.
You have tight calves?
Right one, yeah.
Can you put your foot up? Okay. Knee extended. Okay, take your shoe off so we can see your foot. Andrew, you have a question?
Yeah. So for your original example, when you're trying to flex the knee and extend the hip at the same time, would you have a passive insufficiency in the rectus femoris in that situation?
No, passive insufficiency of the rectus femoris. It's a good question. Give me 1 second. Keep your knees straight. Okay, dorsiflex your foot. Come on, stop. Keep that knee straight. Okay, excuse me. Now bend your knee slightly. Bend. Okay, release your foot. Bend your knee a little bit. Now dorsiflex your foot. Where does he have more motion? When his knee is bent or when his knee is straight? With his knee bent, because he has passive insufficiency of the gastrocnemius. Who's got tight quads?
Okay. No, you got it.
Andrew asked about rectus femoris. Andrew, why did you ask about rectus femoris? Just questioning. Rectus femoris, is a two-joint muscle, right? That's why you asked. Very good. Okay. So, now, lie down on your back. Both of your quads are tight?
Most of them, that's my right side, but
All right, put this leg up. Put this leg up like this. Put this leg down. Bend your knee.
both.
Okay, as much as you can, not stretching, but just bending. Okay? Got some flexion here? Decent amount of flexion? Yes? Okay. Lie on your stomach. I would stabilize him here, but let's pretend I'm not, because watch what happens. Bend his knee. See that? See what he did?
Yeah.
He tried to put himself on slack to get more range of motion.
Because my hip keeps coming up, right?
Yeah, you're extending your hip. Okay, so stay here. Stay here. Just bend up without getting your hip off. Bend.
That's hard.
Stop. Where did he have more range of motion, in supine or in prone? Supine. So when he's in prone, he has passive insufficiency of the rectus femoris muscle. Okay? All right? Okay. Passive and active insufficiency. All right. Passive insufficiency, when a muscle reaches a point where it can't shorten any longer, we just said that. And I like to always demo first. And passive insufficiency, when a muscle can't be elongated any further without damage to the fibers, occurs in the antagonist, opposite the agonist. You're cool with that, right? We just demoed it. So, and then I gave an example of active insufficiency of the hamstrings. Yes, didn't we just do this? And that's why I put it in writing so that you could read it too. So when I extend the hip and I flex the knee, I can't do both because, and if you don't believe me, ask I'll tell you. I'll tell you what happened when you try to do that. You got a cramp. Because it just didn't have couldn't shorten it any longer, right? And with passive insufficiency, you can't lengthen it any longer. And it only refers to two joint muscles. Do I expect you to be able to demo this or with every muscle in the body? No, because you don't know every muscle in the body. Do I expect you to be able to tell me this with a hamstring or with just what we demoed? Yeah. Okay, to give me an example. All right. So we following that. Dawn, you okay? Yes. All right. And passively insufficient, the muscle can no longer elongate. Doesn't have enough length to elongate over both joints. It can't effectively and efficiently do what it does at both joints because it just doesn't have the length to do it. So we have passive insufficiency. I gave you an example of passive insufficiency of the gastroc, passive insufficiency of the rectus, passive insufficiency of the hamstrings. We do have passive insufficiency of the long finger flexors and extensors. Yes, we do. So, but I'm holding that. Here we go. Tenodesis, use of passive insufficiency of the finger extensors and flexors. When is this important? If somebody, and I want you to I just want you to all just put your pens down for a second. Okay. And I want you to just supinate your forearm. Just supinate your forearm over, I don't know, just passively, just drop your forearm. What happens to your fingers? Your wrist extends, and what happens to your fingers? Fingers close. When you pronate your forearm, what happens?
Fingers extend.
Your wrists flex and your fingers extend, right? Because of passive insufficiency. So, passive insufficiency of your finger extensors, passive insufficiency of your finger flexors, right? Okay. Is this something you're trying to do? So is it volitional? Well, volitional means you're doing it on your own, right? Is this a volitional activity? Are you saying fingers closed, fingers open? No. This is a passive thing. It occurs just because you throw your hand into flexion and you throw your hand into extension. This is really super duper important when you work with quadriplegics. Because if you're a quadriplegic and you're a C5 quadriplegic, you do not have volitional movement of your hands. You do not. You can lift your shoulder, you can bend your elbow, you can supinate. You can supinate. So this is a function, this can be a functional use for a person who doesn't have the innervation of these muscles to do it volitionally. So as they throw their hand into pronation, the wrist flexes and the fingers open. As they throw their hand into supination, the wrists extend and the fingers close. So they use this for function. This is known as tenodesis. Tenodesis. Okay? Opening and closing of the hand are accomplished through this passive range of motion. Long finger flexors have passive flexion through active extension, right? And these are critical in patients with quadriplegia or tetraplegia. It's another word used for quadriplegics. Okay? Because it is the difference between them feeding themselves and not feeding themselves. Feeding is such a functional activity that we all should have, right? If you start stretching when we do passive range of motion, someone's wrist extensors and finger extensors, you have taken away their tenodesis. You have taken away their ability to use their finger flexors and extensors. Okay? That's why I can't emphasize how important this is. All right? When you start doing range of motion and you're doing it with quadra or tetraplegics, never extend their wrists and fingers at the same time. If you want to do that to each other just to get a nice stretch, that's fine. But never do it to a person that is paralyzed. Because they will lose their ability to have a functional hand. Okay? Passive insufficiency. All right. We're going to be doing exercise next week. We're going to do passive range of motion, so let's talk about it a little bit. Why do we do exercise? Improve circulation, increase the ability of that person to move, increase strength, right? We do resistive range of motion. We also do it to help or assist with the healing process, to increase cardiovascular fitness, function, endurance, pulmonary function. These are just to name a few. Decrease edema. Increase or decrease pain as we decrease edema. Prevent loss of motion and atrophy. However, passive range of motion does not prevent atrophy. Passive range of motion does not prevent atrophy. Okay. Develop body awareness. How do we know, what's the word for knowing where our body is in space? Proprioception. Proprioception, knowing where our body is in space. We have proprioception. If we have proprioceptive difficulties, We may have an antalgic gait, we may have a wide base, we may be ataxic, right? For proprioception problems. We may be cerebellar, we may have cerebellar problems, and we'll talk about neuro a little next week. Improve our posture, improve our ADLs. What's ADLs? Promote relaxation, which we said was important, because if our traps are firing all the time, like some of you young ladies back there, relax those shoulders. Think about it. Release our endorphins. What are endorphins and our enkephalins? What are they? There are normal endogenous opiates. We make them ourselves. Endogenous, we have them in our body. So we release these endogenous opiates when runner's high you hear all the time. So you do exercise, it makes you feel good, right? A lot of stuff you do makes you feel good. You're getting a release of these endorphins. And also for muscle re-education, because if you're going to put an electric stim on somebody and you're just going to tell them, all right, this machine is going to make your muscle work. What do you usually see the therapist say? When the machine is on, I want you to kick your leg, right? So that not only is this is not a passive thing, it's actually an active range of motion with assistance from an electrical stimulator, which will help increase muscle fiber and increase strength of the muscle. Okay. So passive range of motion, maintain soft tissue and joint integrity, important. Maintain the elasticity, which we talked about. Increase circulation, increase synovial fluid. Synovial fluid is important to increase within the synovial membrane to make sure that the joint doesn't get stuck. Decrease pain, increase healing. Contraindications for passive range of motion. If it disrupts the healing process, and we're not supposed to do range of motion at all. That's a contraindication, right? Another contraindication, positive vertebral artery test, right? What's a vertebral artery test? What's it also known as? Quadrant test. And how do you do it? Well, if you don't know, you better know for Tuesday. Okay, quadrant test. So that's a precaution. Let's see. And as I said, passive range of motion does not increase strength. What's the difference between active and active assisted range of motion? Active range of motion, you say to me, can you do this? Can you do this? Yeah. Can you do this? I can only go this far. So now you come and you help me do the rest. That's active assisted range of motion. Active assisted range of motion can also be done like this. Right? I know you're flaccid and it's coming back and we're getting some tone. So now I want you to do active assisted range of motion with this arm. Oh, but I can only go this far. Well, use this cane and use this arm to lift this up. Okay? Or you see in clinics all the time those pulleys. So sometimes they even tape your hand to the pulley and the person does this. So this active assisted range of motion. Passive range of motion is completely done by you, the therapist, or some kind of an external device. So a CPM, which is known as a continuous passive motion device, is used to increase knee flexion. It's also used to increase shoulder flexion, wrist flexion. You don't see them so much in facilities anymore. But continuous passive motion device is known as a CPM, and that passively moves your limb. Okay? All right. Oh, contraindications comprise cardiovascular status. Somebody's got cardiovascular problems, and you need to find out if their status is okay for them to do it. Precaution is Valsalva. What's a Valsalva? Forced expiration against the closed glottis, decreased venous return, decreased, right? Increase of peripheral resistance, increased blood pressure. Okay. Reasons you do resisted range of motion. Increased strength, right? Resisted range of motion. Increased strength, increased endurance. So we do it with a person that has low endurance. Would we do resisted range of motion exercise with somebody with an acute inflammation? Absolutely not. All right, somebody's got an acute inflammation, we rest them. We don't do resistive exercises. Okay. Cardiovascular status, again, DVTs. What's a DVT? What happens when you have a DVT? It can free itself. This deep venous thrombosis can become an embolus. An embolism can travel to the lung, can travel to the brain, right? Can kill you, right? That's why I have compression stocking on right now, because I spend a lot of time standing. I'm trying to walk a lot, but I don't want to risk a DVT. Precautions, DOMS, delayed onset muscle soreness, overwork of the muscle. These are all precautions with resistive exercises. Osteoporosis, remember? Pathological fractures. Ischemia, a decrease in blood supply, or a decrease in the amount of oxygen to the blood. Ischemia. PVD, peripheral vascular disease, and a Valsalva. And now, we're going to end with this. Oh, I don't know if we should end with this. Yes, okay, we'll end with this. But somebody just left. I'll say it again in class, or make sure that he knows it. He had to leave early, but make sure. Okay, so joint mobilization, passive motion with oscillations or sustained stretches to increase mobility. We do passive range of motion at the joint caps. So there's physiological motions that the patient does voluntarily, so volitional movements, and there's accessory motions. Patients can't do them, but they're necessary for normal range of motion. Think about the fact that we need our scapula to upwardly rotate. Can I say to my scapula, upwardly rotate? Go ahead, upwardly rotate. Come on, upward. It's not moving. If I use my arm and I move, the scapula moves with it, with the shoulder. So I can't do it alone. Or also joint play. It's the give in the joint capsule itself. So if I took his finger and I wanted to look at joint play, I could do a little traction and then move the joint up and down. You feel that?
Yeah.
So that's a little joint play in the capsule itself. He can't do that himself. He can't say, finger, move up and down, right? I mean, you know you can't do that. All right, so we're going to do that with each other when we do we'll do joint play next week on each other when we do passive range of motion. Here's the important thing. We're going to talk about the concave-convex rule. And there's 4 different types of glides. Remember we said that the arthrokinematics and the osteokinematics, when we want the osteokinematics of some bone going up, so we want to go in an upward direction or a forward direction, the arthrokinematics, or what's happening at the joint, is different depending on what the shape of the bone is. Okay, so we have glides and we have rolls. As the bone rolls up, the bone either needs to glide with it or glide in the opposite direction. Okay, so far so good. I will tell you this. There is a rule known as the concave-convex rule. When the shape of the movable bone is concave, you move it in the same direction the bone is moving or the same direction you want it to go. Okay. When the shape of the bone you're moving is convex, you glide it in the opposite direction that the bone is moving or the opposite direction that you want it to go. All right, let me just show you. The humerus, if I kept moving the humerus on a scapula, and I'm moving the humerus in an upward direction for flexion, if I kept moving it, where would the roll, as I'm rolling upward, it would lose congruency. It wouldn't be able to roll on that glenoid, it would roll off. So it has to glide in the posterior direction. Easy way to remember this, I'll tell you 2 ways. Easy to remember the concave-convex rule. The word concave has an A in it. So A for same. So if the movable bone is concave, move it in the same direction you want it to go. Glide it in the same direction you want it to go. If the movable bone is convex, move it in the opposite direction you want it to go. Okay, I'll give you another example. What's this? Convex? Concave. Okay. This is the bone. I want the bone to go up. And this is convex, right? So I want this to go up. Which way is it gliding? Posterior or anterior? Or anterior or posterior? So it's gliding up or down? Down. Here's the concave, I want this bone to go up. Which way is it gliding? Up or down? Up. Okay, so think of this. If I want this bone to, so the glenohumeral joint, if I want to increase flexion, I'm moving the humerus on the scapula. I'm moving the humerus on the scapula. Humerus, scapula. So the bone is moving up, but I have to glide it down. Okay? The bone is moving up, so I have to glide it down. Without lying him down, can you just sit? Okay. I'll do the abduction, because abduction's the same thing. I need to have that bone come up, right? But I'm gonna glide him down. And when I do this, which way do you feel your bone is moving?
My humerus is going down this way.
No, not this part, this part,
Which part?
this part.
That part? A little bit up.
Yeah.
Yeah.
It's going up. All right, so what I would do is I would, see, I was just trying to stabilize you. So
Yeah.
you would be stabilized on a table. When I push down, it's going up.
Yeah. I also
Okay.
feel this going down though.
Yeah. This I'm gliding in a posterior direction, but inferior direction actually, but it's moving up. If I was doing it from this position, that's different. I'd have to lie him down, and you guys can't see that. Okay, that's the concave convex rule. Concave convex rule states that if the movable bone, so we got a glenoid and we got a acetabulum. If the movable bone is convex, we glide it in the opposite direction we want the bone to go. Okay? So how do we increase knee flexion? All right, I'm sitting like this. This is making you think, right? Uh-oh, making you think too much? You want to not come anymore? I want to increase knee flexion, I'm out here. What bone am I going to move, the tibia or the femur? Tibia. What's the shape of the tibia on top? Concave. Concave. When I glide this tibia, which direction am I going to glide it, posterior or anterior? Posterior. I'm glide it in the same direction I want the bone to go. I want the bone's going to go down, I want to glide it down. You got it? All right, you got to think about it, you got to read it, you have to absorb it, okay? So we'll end here.